And welcome to a Shot in the Arm podcast. I'm Ben Plumley. We have an incredible lineup for you in this episode as we do these special episodes from the International AIDS Society's 2019 AIDS Conference. As ever, I'm joined by my co-host, Yvette Raphael, Executive Director of APHA.
Yes.
It's great to see you. We're also joined, and this is quite an emotional moment for me, by Defendant Nhamo from the Pangaea Zimbabwe AIDS Trust, and PZAP is the successor of the Pangaea Global AIDS Foundation that I ran. So, Def, it's really great to have you here.
Thanks for having me.
And I'm really privileged to have one of my heroes in the AIDS response, Dr. Andrew Ball, who is the director of the WHO Department of HIV, Viral Hepatitis and STIs. Andrew, thanks so much for joining us.
Well, thanks, Ben, for inviting me.
Yeah, it's terrific. So, Yvette, as my father likes to quote from Shakespeare, what news from the Rialto? What's going on today?
Oh, Ben, as South Africa, while being here, we are faced with almost a challenge where one of the big NGOs that I believe in and that got me to start speaking about my own HIV status is entangled and embroiled in a sexual harassment cover-up issue and case back home in South Africa. And we, as a person, I obviously was caught up between the organization that I looked up to and also what I believe advocacy is around. And most definitely very sad news coming from home, but also just to remember that TAC, the Treatment Action Campaign, was nominated then for a Peace Award, for way back then, a Nobel Peace Prize. And now we are here. It was one of the organizations that challenged UNAIDS with regards to the sexual harassment case for Michelle Sidibe in the forefront. And now we are here. And I have many friends and comrades at Treatment Action Campaign that I look up to. But I have to do what I have to do, that we as community have to be able to call each other out and ensure that we stay on the right track and do not do what we say some of the things that we don't agree with publicly when it happens at home. So yeah, I'm a little bit all over the place emotionally, but I'm at home and here as well. So it's where we are. Yeah,
it is. And I think if there's one thing that this conference, perhaps more than any other, has really taught me is that the science and the and human rights are really like a hand in glove, like strands of DNA together. And I think we have to really think about not only what we do, but how we do it, which I guess is the issue that's been underpinning our discussions over the last few days. How to implement the science, how to make sure communities do what's best for them.
Yeah, I mean, communities have to set the agenda themselves and have to be at the helm and leading those. And sometimes hard decisions have to be made. But it brings me to my dear friend and comrade, Dr. Nhamo, definite Nhamo from Zimbabwe. What is your big takeaway from this conference, the IAS, as somebody who works in science and is a researcher herself, and now we're here, 2019 in Mexico?
For me, it's prevention. And the sad thing is we have a product that has been shown to be efficacious. We have oral PrEP. We know it works when you take it. But what's coming out of this conference is the rise in STI cases when you talk about PrEP. For me, that's disheartening. It's like we have a win and now we have a low. And I'm not too sure whether to celebrate us getting a new prevention option in the prevention basket when we have a rise in STIs. So it's like a catch-22 for me, and I'm still trying to understand what this means.
And most definitely, the conference is showing some of the successes. I was attending the HIV testing and PrEP conversation or session this morning, and it was showing just how effective PrEP is. And we should not despair, but I think we should also look forward to how we merge these two and teach our communities around healthy sexuality, healthy sex life, and how to make HIV/AIDS part of their lives.
I mean, that's a really interesting comment that you make about STIs. And Andrew, I don't know how much WHO can say about the data, but I've been really intrigued that in many settings around the world, PrEP hasn't been associated with a large number of STIs, that you basically engage people into a continuum of prevention services. Is that something that perhaps WHO has seen, or do you share Def's concern?
I mean, certainly WHO actually has had a session, a satellite session on Sunday, specifically looking at the issue of PrEP and STIs. And we actually put out a document to actually look at some of the key issues. We had some very interesting data that was presented, including from Australia, showing, extraordinarily high rates of a broad range of STIs in those communities, those individuals that take PrEP. Now, our view is very much that PrEP provides an opportunity. As you said, it is an incredibly effective tool, a prevention tool, where we can't ignore, if there is something effective out there to actually put it into use. But in doing so, we know that we have to use it in a way in which it's going to have an impact and actually be integrated with a much broader HIV response. So the view that we have is that what we need to do is to link PrEP services very much with STI services, and we see a win-win situation. PrEP uptake has been very low in most countries. It's been limited to a few populations that have really embraced it. And so to actually expand the use of PrEP, particularly for those who are at greatest risk, we need every possible avenue to promote PrEP and to enable for it to be prescribed and for communities to be educated. At the same time, it does provide an opportunity, PrEP in itself, of attracting populations, individuals who might be at high risk of not only HIV, but of STIs. It can encourage them to come to services, to be tested, and then linked to treatment very quickly. So the whole idea of bringing together PrEP and STI services, I think, is going to be a remarkable addition to the way in which we can expand STI services, to bring people in, particularly those who are asymptomatic, to offer testing, to diagnose early, to treat, and then really interrupt the transmission that is occurring.
I loved that you said test, because that's been one of the things I've been banging on this week about the importance of testing really as an entry point for prevention and treatment. And, you almost can't think of PrEP without it being part of a continuum of services. But definitely, how are things going in Zimbabwe? Because you were working on the rollout of PrEP a couple of years ago. How has that played out?
So thanks, Ben. And we are still working on rolling out of PrEP. And what we did is, starting 2016, we had our guidelines launched in Zimbabwe around PrEP, and now we're scaling up PrEP. We started off with small demonstration projects, mostly funded through PEPFAR under DREAMS. But now we have a national scale-up program, we have our PrEP implementation plan in place, and we have over 74 facilities that are now delivering PrEP in Zimbabwe, which is a huge stride for us.
So how many people are on PrEP, do you think?
So we have about 11,800 people on PrEP as of June 2019, and we celebrate this stride. For us, it's huge. Like, now we have 11,800 people on PrEP. And what we are seeing, though, is just like in other countries as well, we are seeing that huge dip in month 1 and month 2. But we are not yet too sure in terms of measurement whether this dip is because people have changed their behavior or they found alternatives that work for them. But this is something that we're still trying to monitor and trying to understand as a country. But we are celebrating the 11,800 people on.
That's a huge achievement.
It's amazing for us. Yeah.
I mean, it's probably. I think of the East Bay in Oakland, California, and we really struggle. That's an incredible number.
Yeah, in South Africa is struggling as well, and congratulations to the advocates and the women and the issues around getting PrEP in Zimbabwe. It can only be difficult, and South Africa is a little way ahead of time with PrEP, but 14,000 for me is dismal in a country where we have such a huge number of new infections yearly, weekly. We're counting weekly at 1,600 women.
Wait, so 14,000 people are on PrEP in South Africa?
Yes.
And nearly 12,000 in Zimbabwe.
Yeah, it's a problem. And also to know that globally, 450,000 people are on PrEP, and the countries where the HIV rates are so high and new infections are so high are doing so dismal with PrEP uptake. And I think our governments need and can do better to ensure that PrEP becomes part of our healthcare system.
Andrew, which countries stand out to you and stand out to the WHO as sort of examples of best practice when it comes to comprehensive prevention?
I think, if we're actually looking at PrEP integration, we have the experience that has just been described. I think that there are a number of countries, such as Australia, that moved very quickly and has really a very comprehensive program. It has very much involved communities. The advocacy has been strong. It's been focused in particular populations, particularly men who have sex with men. But there are few and far between the actual countries that have taken it to scale, that have gone beyond recommending it, putting into place possible approaches to delivering PrEP, but then to actually get the uptake remains challenging. And it's great to see that we are seeing this experience in countries where the population is very different to where the early uptake of PrEP was being promoted. And where, there's always, questioning as to what extent would it be relevant given the broader range of other issues, such as just getting enough people on treatment to start with and retaining them on treatment.
And so, Def, how is treatment being rolled out in Zimbabwe? I mean, you said this conference is prevention, but how is the treatment side going? I know that that's something that PZAP has been very, very involved in.
Yes, so treatment is also going on well, and Zimbabwe also adopted the test and treat, and that is going on well. We do have challenges where, in terms of communication, people receiving treatment did not understand how we had a batch of drugs that the expiry date, they had expired.
Oh.
But what happened was from the Medical Controls Authority of Zimbabwe, they had extended that shelf life, just like any other drug can have the shelf life extended. And there was a demonstration a few weeks ago on that, and the ministry was explaining to the people who are affected, the people who were part of this demonstration, how this works, how they had extended the shelf life so that people understand. But just like any other country, we do have those challenges, but the treatment is really going on well. Even our treatment cascade, we have about 85 people who are on treatment of those who've been tested. So in terms of coverage, we are doing quite well. We could do better, yes, but I think we're on the right track.
That's true for all of us. But just to get the numbers right, how many people are on treatment in Zim?
We have about 1.2 million people, sorry.
Yes.
Wow. And how many have we got in South Africa on treatment?
Over 4 million people, and we have 7.3 million people living with HIV in South Africa. So for us, it's again the halfway mark, but we can do better. We need more people on treatment to reach the 1990 goals and to ensure that people do stay and get to a point of being undetectable.
Andrew, you look back on our careers, back to the early 2000s, we would never have guessed this, right?
Not at all. And even looking back further to even contemplate that treatment was going to be made available in most countries was just a dream. So it is really a public health, success story. One of the greatest that keeps on being told as a demonstration of how really what community action has led to a very accelerated response. And associated with that, it's not just how treatment has scaled up, it's everything around it. It's addressing aspects of service delivery, the research, from clinical basic science to clinical research to social science, addressing human rights issues, disparities in access to services, the way in which services are now being delivered, the thinking around communities and their role in the response. So it's not just about the numbers of people on treatment and the numbers of people that have been saved. It is very much around transforming the whole public health system in a way in which it's going to benefit or is benefiting broader public health measures. So it's never going to be the same. It's never going to be the same, even though we talk about maybe some of the complacency around HIV. We need to remember that it has created a movement where maybe our expectations around HIV need to be, put into the context of what has been achieved more broadly and those opportunities.
Yeah, and funny you say that, because I always say we need to celebrate our gains. We need to remember where we come from so that we also can have that moment of patting ourselves in the back, where Africans and people from the SADC region or black and brown people were not trusted or could not be believed to be able to understand time and take treatment and continue and staying on it. And one of the big things I celebrate is the fact that the old people living with HIV in South Africa are the ones who are adhering and the ones that refuse to change the handful of pills that they still get to a 1 tablet, because they say, if it ain't broke, don't fix it. The dolutegravir is there, but why should I then change treatment when it really works for me? So I want to just give a shout out to all of those old guard activists and women and people living with HIV who is pulling and being that beacon of hope for the rest of the world and other people living with HIV.
You mentioned, oh no, sorry, Def.
Yeah, so for me, just following up on what Yvette is saying, I think what we need to do is take the lessons learned from treatment, all the differentiated care models. We've done a lot to invest in differentiated care, and now we know at least what works, what doesn't work in terms of treatment. But for me, it's translating that into prevention, because what we want to do is make sure that person who's negative maintains their negative status. Let's make prevention sexy. Just like we say those who are on treatment should adhere to their treatment so that they become virally suppressed. We're talking about U equals U. Let's translate that to prevention so that we take advantage of the lessons learned in treatment. Most definitely.
You mentioned differentiated care, and Andrew, I know this is something we've been talking about over the years. It'd be really interesting to see both of your definitions of that. And I don't know, how would you describe differentiated care?
So for me, differentiated care is taking services to the people, whichever way, meeting you at your point of need. If you need your drugs at home, let's bring them to your house. If you want to come to the facility, you should come to the facility. So different models of delivering the same services. But for me, the catchphrase is meeting you at a point of need. If you need this service, we'll take it to you. If you want to come to us as a healthcare provider, you come to us. But those different models.
Yeah. I mean, Andrew, we worked on optimization of treatment for a number of years, and differentiated care came into that. How do you see, from a sort of a healthcare policy perspective, the role of differentiated care?
Well, honestly, I mean, differentiated care has been a concept that has been around for a long time. It may be has been defined as such, but I recall, back when I was a clinician, that we would organise our services in a way in which those who didn't need specialist care could be treated in the community, could be treated at primary health care level, and that there were very clear referral systems that enabled those who were sick and could not be managed close to their home, where they live, that they could be referred very easily to the next level of care. So differentiated care is not a new concept. Maybe it has been better defined, and it is now helping us to have a much clearer idea as to how we organise and design our health services, to actually look at what is the impact that we are achieving through the different services that are being delivered. And we see very clearly that those who are stable, are well, their retention in care, their adherence is much greater if they are managed at a community primary health care level. But of course, we recognise that those who are sick, or where the situation, the management of their particular illness is complicated, that we have a way in which we can deal with that as quickly as possible. So it results in better outcomes, greater impact, and more efficient. Less costly, because you are investing in communities rather than in tertiary hospitals.
Yeah, most definitely. I mean, in a case of South Africa, where we're moving again back to the community healthcare workers and ensuring there's the school health program. You can ensure and you can identify and start working with young kids and in the school system to make sure their eyes are tested, get HIV testing at schools, as well as ensuring that when we talk integration, how we can use lay healthcare workers to give services like contraceptives and routine HIV testing in the households and where the people are, and they don't have to go and look out or wait for an event. One of the things that stresses me is that we test people at events. We put up a tent and we call everybody to test. But what about the moment when I feel I want to test?
Yeah, no, I think that is where the future of the response is going to be. But coming back to the conference and the data, I think a real highlight has been the data on dolutegravir in treatment. And I've got to say, Andrew, I've been really impressed that, last year we had this potential issue of neural tube defects in Botswana. And I've been really fascinated at the way WHO has sort of tracked this and managed to update its guidelines really rapidly. And, WHO came out with revised guidelines, this year after the data was presented, showing, the signal is not as strong as we thought. How was WHO able to do this?
Well, it wasn't just WHO. It really involved many partners and, investments from some of the key donors, plus the commitment in countries such as Botswana, in Brazil, to actually generate the data that is critical for us to make decisions. Now, just to make you aware that when WHO came out with the guidelines last year, we were in the process of going to the Guidelines Review Committee before the safety signal was announced. We had everything planned with regard to how we were going to present the data and the key discussions around the PICO questions, the recommendations that needed to be addressed. So we were taken by absolute surprise when the safety signal was announced. Now, clearly, that was a wake-up call to us. It demonstrated very clearly that how important some pharmacovigilance is to actually ensure that we are aware of the potential risks of any treatment that we're providing, particularly when we are getting to a stage when we're looking at very large scale up. So it was the preparedness that everybody was expecting for dolutegravir to come on to be promoted and to be widely scaled up. And when this alert came out, and possibly it could have been managed in a better way to so that countries could make more informed decisions, that communities could have been involved more in understanding what the safety signal meant and what the options are for communities, and for the governments to understand how it might influence their policies and their treatment rollout. Sure, it could. We learned quite a few lessons there as to how we might deal with a similar situation again.
From this side, it looks like, WHO has been completely on top of this, and so, huge kudos for you. I remember scratching my head with you, oh my gosh, maybe 10, 15 years ago about the complexities of the grading system and all the issues that have to be taken into account. It's very interesting because, again, from the way that you're presenting the data, you're deliberately not letting us fall into this trap of, dolutegravir is the next magic pill. And there was a comment from our friend David Barr this morning about how we have to avoid imagining that dolutegravir is going to end the AIDS epidemic. But I've got to say, I've been so impressed on how WHO has stayed on top of that. So I think, kudos to you and your team. And
maybe I didn't quite finish the story. So I like to tell long stories. I like to. It was the safety signal that really caused a lot of havoc early on. But it also resulted in substantial support from NIH to actually expand the studies that were providing the data that was required to make a more informed decision, because this was a safety signal. It wasn't clear exactly what the implications were. So it stimulated investments in further research to actually look at what the issues are, an opportunity to engage with women living with HIV, to engage with communities, with governments, to actually understand what the issues are, so that we were very prepared to look at what the broader range of issues were that we needed to address that possibly wouldn't have been the case if we had just issued the guidelines straight off without any of the safety signal. It also provided us with an opportunity of undertaking some modelling to actually look at what the implications were with regard to, if we introduce dolutegravir and if there is the risk of a neural tube defect, vis-a-vis if we continued with the old regimens, with the Faverins-based regimens. We also had more and more data that was coming in from our HIV drug resistance surveillance work. And so within a year, we actually had a substantial amount of new data that could really give us much clearer thinking as to what the recommendations should be. We not only had the information with regard to the risk of neural tube defect, and that hasn't been fully answered yet. You know, there is ongoing data to there's ongoing work to actually see to what extent the risk is there. But with the modelling, it clearly demonstrated that by transitioning to dolutegravir, that there would be more lives saved, that there would be fewer transmissions of HIV from mother to children, and that there would be healthier populations. We also had, and we launched at this conference, our latest report on HIV drug resistance. Yeah. And shockingly, we are seeing an increasing number. In fact, the majority of countries that we were specifically focusing actually reaching drug resistance to efavirenz and nevirapine exceeding 10%, which is the threshold for us to think, look, something is going on here.
Yeah. Well, here's the thing. Andrew Ball stopping me in my tracks and telling me to come back to... He's done that to me regularly over my career, and brilliant job. I mean, I'm really interested in dolutegravir. What does Zimbabwe think about the drug? Is it something that's being rolled out? Is there interest in it?
So Zimbabwe is definitely interested, and there was a process that we went through. We had consultations with community members to try and understand what they would want, what they knew about dolutegravir, what were their fears, and the country then resolved that they would, anyone who tests positive right now would be initiated on dolutegravir. But those who were on treatment before, they would continue on their regimens simply because of logistical issues. There were drug stocks that were there, and the country wouldn't just throw away those drugs. So people have to continue on those regimens until such a point that those drugs are all used up, and then they will then transition to dolutegravir.
So, I mean, Yvette, I'd welcome your thoughts on this. I mean, Andrew, what you're basically saying is that at 10%, the NNRTI class, a class of HIV drugs that is widely used, is now really at risk of the virus being resistant to.
Yes, and I think it's also over the use. These drugs, people have been on them for more than 10 years, and obviously that's the time when you see resistance. And also, what's exciting and you know, DTG is that superior drug that resistance can happen within a month. And not resistance, what I mean is undetectable. You can become undetectable really quick. No drug resistance, as well as the pill burden is much less. So we're seeing a good view of where we're going with HIV treatment. Dolutegravir won't answer all of the questions, but it will definitely lessen the burden of so many, things that I call the structural issues that makes it so difficult for people to take the drug. If you have to take, and it's such a small drug and so easy to take. I was jealous that I will never be able to take DTG, but as a regimen, but maybe as a salvage drug. And that was what my doctor told me. Leave it for the future, because I'm on second line. And it's exciting to know that there is this future with something so revolutionary as DTG. And South Africa is one of the countries that's looking at rolling out DTG and making it much easier for people living with HIV.
It begs the question, you know, where are we going with the AIDS response? You know, what's the state and what happens next?
I mean, again, the story hasn't finished with dolutegravir. in that, it's a great new addition to the treatment portfolio, but it's not the end. Mm-hmm. We are going to need new antiretroviral drugs, and even better antiretroviral drugs. And we're already seeing that there still are challenges. We're seeing evidence of weight gain in some populations of those using dolutegravir. We have to look at that further. We recognise that the costs are high in many countries, and decisions around access to dolutegravir is being determined for economic reasons. So there's still a lot to be done, and let's not just say that dolutegravir is the solution. It's an extremely important addition to the treatment portfolio, but let's not stop there.
Yeah, and it takes us to: do we have the tools to end the AIDS epidemic as globally? Do we have those tools? Is anyone optimistic about where we are with regards to tools for ending AIDS? That's one of the things that UNAIDS like to say. By when are we ending AIDS, by the way? 2030? Or when?
2030.
Yes. Do we have the tools? That's my question to both of you.
I think because society is dynamic, people keep changing, even the way they behave. We might think we have a good grasp and we have a good understanding of how people behave, how they change over time. But because our society is dynamic, things will keep changing, and it's inevitable. We are going to have to keep looking for more efficacious drugs, come up with more strategies to reduce new infections, because people change behavior. Behavior is modified depending on where you are, your age, your context. So those things are going to keep us searching for newer and better drugs, better strategies to cope with our situation.
We haven't been effective in some populations ever since the beginning of the epidemic. We haven't prevented epidemics among people who use drugs, sex workers, transgender people in prisons. We haven't been able to get them on treatment, and we haven't been able to keep them on treatment. So the successes that we've achieved haven't been fair. They haven't been shared across all populations, all communities.
Is that therefore what is meant by universal healthcare? 2019 is the year of UHC, universal healthcare, and I know you are heavily involved in it. Is it about equity, or is it really just about another political slogan, do you think?
Absolutely not. I've been converted to universal health coverage, and I've always been a skeptic as far as new sloganeering. And universal health coverage, the definition is that all people can access the health services and health commodities they need, which are of high quality to achieve impact without experiencing financial hardship. Now, that covers all bases, basically. It makes us actually think about, well, what does that actually mean? It means that we have to look at how can we deliver services to reach all populations. So you cannot achieve universal health coverage if you achieve 90% coverage, but it's all in the general population, and key populations miss out.
So it sort of begs the question, do we have the leadership to deliver this? Chris Collins said in an opinion article today, Chris Collins from Friends of the Global Fight, we don't need a miracle. What we need is leadership. And I'm really interested in how we do that, particularly, Def, given the changes in Zimbabwe over the last year. Do we have the leadership?
It's a yes and no, because the leaders say they are trying as much as possible under their circumstances to do what they can. And depending on what lens and whose lens you're looking at it, you might see as though they're not doing enough. There's always room to improve. But I think leadership is critical in such circumstances, but we would never have perfect leaders, but it's working with what we have.
And the leadership crisis has always been for African leaders, right? But now recently it's just global. So Ben, tell me, what do you think of the new UK Prime Minister?
Oh, that's not fair. That is so not fair.
But it's fair. You always ask us about Jacob Zuma and the new guy in Zimbabwe.
Yes,
so
I think it's a good question
I'm
for you
interested
there.
to hear.
Well, I'm not a fan of a wannabe Winston Churchill. And hopefully he will be the shortest Prime Minister in UK history. But it does, I'm going to get you for that. It does beg the question how we work with leadership in what is essentially a populist era, how we are able to make the science work for people. And Def, starting with you, I would really love to know how you and your team has worked with the Ministry of Health and Childcare. And you're describing some numbers that are really extraordinary.
So in terms of our Ministry of Health, we started working with our Ministry of Health a long time ago, Ben. I think we now have our relationship dates since inception for PZAP. And we've always had like a great working relationship with them. They're very supportive of the work that we do. And whatever we do in Pangaea, we work closely with the Ministry of Health. And I think that helps us in terms of strengthening the programs that we've run. And we're grateful for that support. If we go to them with any project, any activity, they are supportive. And we do have our challenges in our country, but in terms of the Ministry of Health and how they're working as a country to deliver health services, I would give them kudos under the circumstances. Yeah.
I mean, Andrew, I know you can't comment on individual governments, but you know, I look at you and you've been devoted to evidence-based policy making. You know, when you were a clinician, when you came to the WHO, how does, I'm trying to frame this question in a way that you can answer it, but how does WHO work in a populist era?
I mean, WHO has worked ever since it was established in extremely difficult circumstances, whether they're political, physical, financial. And so, yeah, I mean, this is day to day. I mean, what is happening globally is nothing new as far as having public health challenges. What we can do is, and we recognise politicians have to make very difficult decisions. They often, particularly in the area of HIV, make highly unpopular decisions and policies that are going to be effective. And what we have to do in public health is to make that process as easy as possible so that we give them the easy way out of a very difficult situation. And by evidence, the science, developing the tools, the interventions, the drugs that we can demonstrate is going to have a significant public health impact that is then going to have a broader impact on development, financially or whatever, then we can argue that case. Now, whether they adopt our advice is another matter. But we have experience from many countries, way before the current global political environment has become so evident. In working in some of the most conservative countries, where they have been able to introduce interventions that have not been possible in countries which really have some of the most liberal policies. And it's because they've often taken on a pragmatic approach with regard to, what is required to actually address the very specific needs of their communities. So, this is a challenge for us, and it is convincing those policymakers that a good public health approach is not only the right approach, but it is going to make their lives so much easier. It's far from easy, but this is the strategy that we need to adopt.
Absolutely. So in wrapping up, what are your thoughts for the second half of this conference? Def, what are you looking forward to hearing or presenting this week?
That's a difficult one, but I think for me it's re-strategizing in how we conduct our research, prevention research, so that it's easy for policymakers to move research into implementation. So we sort of shorten the gap from research into implementation. If a product has been shown to be efficacious, there's no reason why we should wait 5 years for it to be implemented. So for me, it's looking for strategies to shorten that. If it's how we conduct our clinical trials, so be it, so that we try and relook the way we do the clinical trials to just shorten the gap from research to implementation. For me, it's a big one, and it's got huge implications.
And Andrew, what is WHO doing for the rest of the week here in Mexico?
Okay, well, we've actually done a lot of front loading for this this conference. So our big announcements, major satellites, most of them took place on Sunday, last night, some of the pre-conferences. But we're ending up with a very nice session tomorrow afternoon that I'd encourage everybody to attend, and that is looking at political will. Political will, what is required to achieve zero new infections. And hopefully we will be hearing from the presenters some of the approaches that they're taking. And often the solutions aren't globally, they are local. And so we are hearing about the experience from New York City, we're hearing about the experience from a range of other cities, and the critical role of some of the major donors, such as the Global Fund. Political will and the way in which politics worked 20 years ago when treatment really started, when there was really a generation of a major political movement around HIV, the world has changed completely. So it's not a matter of more of the same type of political will, it's a very different type of political will. And that's what people need to realize. Advocacy has to be different, the arguments have to be different, the evidence has to be different, and the people that we target have to be different to make HIV still relevant in order to achieve the extremely ambitious targets that we've set.
Yeah, absolutely. So Yvette, final words to you. What are you expecting for the rest of this week?
So I'm from the country with zero political will when it comes to any of the issues, new prevention and research. So I'm excited to attend the conference, maybe your session, and maybe it will give me some tools to take back and how to gear up a little bit of.
Maybe you can talk. Maybe you can give a presentation.
Yes, on political will. For me, Ben, the big thing still is the issue around young women and girls. I came here as somebody who had everything in my backpack around how I would change what's happening in South Africa for young women and girls, and just how difficult it is for us to get to that population. So I'm still waiting. I'm still trying to find new answers and presentations. Some of them are they look as if we're trying to get to somewhere, but that's still one of my big things. And I hear there's a new buzzword, male engagement. I want to hear more about this thing, male engagement, because as a feminist, that can be a total impediment for me to access treatment, access drugs. So I want to see all of these programs and these new slogans that come up when we go to conferences. I'm going to have to go and update my abbreviation list and, all my knowledge around HIV and AIDS when I get home so that I can also sound cool. So the male engagement has reached the science. So we need to watch that. And I would like to see how we really make that engagement a success without actually further oppressing the woman.
Well, definite Nhamo, Andrew Ball, and Yvette as always. Thank you so much. You are a shot in the arm. I hope you've enjoyed this episode. You can subscribe to us through the usual ways you find your podcasts, and look at our YouTube channel. You can see us in person. So thank you all very much, and have a great day.